Okay, so thank you very much for the opportunity to join this very important, interesting meeting. So my name is Matteo Della Porta from Humanitas, a research hospital in Milan, Italy. And my job today is to try to introduce the concept of the diagnostic and prognostic relevance of anemia in the field of MDS patient. So the most important point from the general perspective of facing with anemia in MDS is that we know that MDS are associated mostly with elderly people. So the incidence of MDS is increasing after the age of 65 in the general population. And we know that the pathological hallmark for almost all patients since the time of diagnosis is the presence of anemia. In these slides, you can see what is the prevalence of chronic anemia, especially mild anemia, in the general population after the age of 65. That means the patient reference population in which we can diagnose often a myelodysplastic syndromes. And the general concept is that the prevalence of anemia after the age of 65 is quite common in the general population. You can see that mild anemia can be detected in up to 15% of the general population. And the leading causes of anemia in elderly people are associated most frequently with iron and cobalamin deficiency, inflammation, or renal failure. In all cases in which a chronic anemia, even mild, is present in elderly people, we can see a significant loss of life expectancy, both in men and in female individuals. And this is also true for MDS. It is interesting to note that, again, in the perspective of the general population, we can see that in around 30% of the patient, chronic anemia is not associated with the leading causes that we discussed before. So we are facing with the so-called unexplained chronic cytopenia. And especially in this population, is quite frequent to provide a final diagnosis of MDS. We tried to provide some insights about the possible prevalence of anemia in the general population, especially among individuals suffering from unexplained chronic cytopenia. And we provided a genomic screening for a large general population of elderly residents in Biella, a small town in the north of Italy, in order to try to define what are the patients that can suffer for misdiagnosed MDS after the age of 65. And basically, we were able to find some mutations that are frequently detected in MDS patients in around 8% of patients suffering from unexplained cytopenia. It means that in general terms, we can expect that a quite high number of persons suffering from anemia after the age of 65 can be associated with a presumptive diagnosis of MDS. And this assumption is confirmed by the evidence that the life expectancy, so the survival probability in this population of patients with unexplained anemia associated with MDS-related mutations is the same of that cohort of MDS patients, meaning patients with a confirmed diagnosis of MDS that are matched for age and sex. So we know that in MDS there is now an emerging clinical impact in integrating molecular information, basically gene mutations, into the diagnostic and prognostic workup of the patient. And there is an emerging evidence that the molecular basis detected in each individual patient can drive the therapeutical choice in terms specifically to address more efficiently mild anemia or transfusion-dependent anemia. So we have the first question to the audience to be addressed. And we have a patient with a diagnosis of low-risk MDS, suffering with anemia, without 5q deletion, and without additional cytogenetics abnormalities. The question is, what is the most important molecular information that can be considered as a driver for a correct clinical decision to treat anemia? So please provide your choice about the 4 possible answers that are reported here. So I think that in general, your answer is associated with the emerging concept that we are discussing before, that it is important to account for molecular information to provide the correct choice in terms of the most effective treatment of anemia in individual patients with MDS. And most of you indicated that the presence of SF3B1 mutation plus ring sideroblast in the bone marrow, or the presence of TP53 mutation are the most important information that should be integrated in a clinical decision-making process. So in this context, you know that there was a huge effort in last years in order to try to formally integrate this very important molecular information to define a more effective stratification of the patient and to define in a more appropriate way what is the prognosis at individual patient level. So what is the relevance for defining the genomic background in individual patients with MDS in terms of therapeutical decision to treat anemia? We know that in general terms, the most relevant contribution for anemia from a physiopathological perspective is associated with the concept of ineffective erythropoiesis. That means that erythroid progenitors in a dysplastic bone marrow are not able to complete efficiently the maturation process, thus leading to an excess of apoptosis within the bone marrow, and finally leading to decreased hemoglobin level in the peripheral blood. So we know that according to the specific genomic background of the patient, we can define 2 different scenarios that are both associated with the same physiopathological process of ineffective erythropoiesis. And as you can see here, the first scenario is represented by MDS with 5q deletion, in which ineffective erythropoiesis is associated with a specific ribosomal dysfunction. And this scenario accounts for around 10 to 15% in the whole low-risk MDS population. On the other hand, the second scenario is associated with the presence of specific gene mutation, especially splicing gene abnormalities, most including SF3B1 mutation. That means that in the great majority of the patient, of low-risk patient, anemia is associated with ineffective erythropoiesis due to splicing abnormalities. What is the possible implication of these findings in terms of therapeutical decisions? We discussed that in patients with MDS and del(5q, anemia is associated with a specific ribosomal dysfunction. That means specifically haploinsufficiency of a gene called RPS14 that maps in the common deleted region of del(5q. That means that this dysfunction of RPS14 gene is detectable in 100% of the patient carrying del(5q. And as you can see here, there is a lot of human diseases that are caused by specific genomic abnormalities in ribosome. And as you can see here, for each individual disease entity, there are specific mutations leading to a specific and distinct clinical phenotype. But in most of the cases, we can find in a significant proportion of the patient anemia associated with bone marrow failure and an increased risk of developing acute myeloid leukemia. That means that there is possibly a common mechanism driving ineffective erythropoiesis in all human diseases associated with the ribosomal dysfunction. And this common mechanism was identified as an abnormal p53 activation in erythroid progenitors, inducing an excess of apoptosis and anemia in the peripheral blood. And we know that in this specific scenario, coming back to MDS with del(5q), we have a specific drug, lenalidomide, that is able to suppress myelodysplastic clone and to favor the expansion of normal hematopoiesis, leading to a sustained erythroid response in the great majority of the patients. On the other hand, in the more frequent scenario of MDS associated with splicing RNA gene abnormalities, there are some new drugs, specifically Luspatercept and imetelstat, that provide evidence for a significant effect in treating especially transfusion-dependent anemia. And Luspatercept was the first drug that completed a clinical development in MDS with RNA splicing abnormalities, specifically in patients with SF3B1 mutation. And we know that Luspatercept is a new erythroid maturation agent that is able to provide a specific inhibition for TGF-beta superfamily ligands and to improve the maturation of especially late-stage erythroid cells, thus improving hemoglobin level for a sustained period of time in the great majority of the patients. So the general concept is that the definition of the molecular basis of MDS is a potent driver to allocate the right and more efficient decision at individual patient level. In addition to that, anemia and molecular information were included in the most recent proposed prognostic score, IPSS molecular, in which both the mutation information on around 30 MDS-associated genes and the severity anemia provide a huge contribution in improving the individual prognosis in the patient, both in terms of probability of survival as well as in terms of risk of leukemic evolution. So, as already discussed by Guillermo, in the next few slides, I will provide evidence that at least in low-risk MDS population, anemia, and in particular symptomatic transfusion-dependent anemia, is now recognized as the most important prognostic factor for the patient. So this means that in terms of perspective and global aim for the treatment of low-risk MDS, there is currently a shift from a more conventional aim to just improve quality of life of the patient to a more ambitious goal to try to improve the probability of survival of this patient population. So we have now a second question for you to discuss all together. That is, what is your perspective on the reason associated with the detrimental effect of anemia in low-risk MDS? In other terms, why anemia is so detrimental for the prognosis of this population? What are the reasons associated with the poor outcome of patients with severe anemia in MDS? You can choose through these 4 different possible answers. So I think that there is a quite strong consensus about the possible detrimental effect of anemia. And we will try to discuss a little bit more in details in the next few slides. So my first point is that we discussed that ineffective erythropoiesis is the main contributor for anemia in MDS, but I would add another concept that this is true especially in very early stage of the disease. According to this study, in which the contribution of ineffective erythropoiesis during the natural history of MDS with ring sideroblast was evaluated by specific and elegant experiment on the iron turnover in patients with MDS and ring sideroblast, it's quite clear that the contribution of ineffective erythropoiesis to anemia is maximized in a very early disease stage. This means that if you have a drug that is working against ineffective erythropoiesis, from a biological perspective, the best way in order to maximize the effect of this drug is to start treatment of the patient as soon as possible. In later stage of the disease, of the natural history of the disease, you can clearly see that the contribution of ineffective erythropoiesis to anemia tends to decrease, and other factors such as inflammation or the expansion of blast cells and leukemic cells in the bone marrow are accounting for the most relevant contribution for anemia in associated with disease progression. Coming back to the question of the pooling, so we know specifically what are the major contribution of the detrimental effect of anemia in terms of specific causes. So in terms of clinical relevance, the largest contribution was provided in low-risk MDS population by an increased risk of cardiovascular morbidity and mortality. For sure, there is also a contribution in terms of transfusional iron overload. And last but not least, there is some evidence that transfusion-dependent anemia means a more aggressive disease from a biological perspective that is associated with an increased risk of evolution into acute leukemia. So, for all these reasons, it is relevant to provide an effective treatment to anemia in all MDS, in all low-risk MDS, especially in those patients suffering from severe transfusion-dependent anemia. This is the perspective of the treatment of a general population of low-risk MDS before availability of Luspatercept and imetelstat. That means in patients treated with recombinant human erythropoietin. And you can clearly see that 30% of the patients failed to achieve any clinical benefit, and an additional 30% of the patients experience an anemia recurrence within 1 year of the treatment. That means that in the great majority of the patients, there was no significant clinical benefit associated with treatment with ESA. So this means that we are facing with a population with unmet clinical need, in which we have to provide an additional effort to improve the outcome of anemia. And the main reason is that anemia is not only associated with a decrease of the quality of life of the patient, but even more important, to reduce survival in this population. So to summarize this part about the clinical relevance of anemia in MDS, we discussed that anemia is the pathological mark of the disease in most low-risk MDS, and is now recognized as the most relevant prognostic factor for patients in early disease stage. We defined two different molecular mechanisms associated with ineffective erythropoiesis in MDS, ribosomal dysfunction in MDS with 5q deletion, and splicing gene mutations in the majority of the patient. And we provided evidence that this stratification of anemia is associated with different clinical decisions in terms of specific treatment at individual patient level. The innovative treatments that are now available, specifically Luspatercept and imetelstat, are associated with higher response rate, and at least for Luspatercept, evidence that the treatment is also associated with a probability of longer survival. We defined that, at least from a biological perspective, the contribution of ineffective erythropoiesis to anemia is maximized in very early stage of the disease. That means that, according to this evidence, treatment with drugs associated with the improvement of ineffective erythropoiesis should be started earlier in the natural history of the disease. And in more general terms, we have increasing evidence that sustained and durable erythroid response in low-risk MDS is associated with an improved probability of survival in this patient population. And this is the most reliable and effective goal of the treatment, in addition to try to improve the quality of life of the patient. Thank you very much for your attention.
So thank you very much. Good afternoon, everyone. Thank you, John and Guillermo, for having me as a speaker. And now we move to myelofibrosis. And first of all, I would like to present some criteria for the diagnosis, which was really changed in 2016, when the diagnosis of primary myelofibrosis included two separate entities, early and overt PMF. These two entities are distinguished by the degree of myelofibrosis, mostly 0 to 1 in early MF and 2 to 3 in overt MF. However, the major criteria also includes the exclusion of other diseases, myeloid neoplasms, including CML, PVET, and MDS. And also the confirm of the clonality, which is mainly driven by the presence of the driver mutation, JAK2, reticulin, MPN mutations, and in their absence, also the research for subclonal mutations should be performed. Please note that primary MF is also diagnosed with integration with clinical and laboratory minor criteria, which includes anemia. That's the subject of this talk today, but also hyperleukocytosis, papillomatosis, elevated LDH, and leukoerythroblastosis. These are IVG MRT criteria 2016 with no significant difference in 2022. And the ICC criteria in 2022 are pretty much alike, but with a more specific focus on the sensitivity of the molecular evaluation. And the molecular evaluations, for example, we must use highly sensitive assays to evaluate the burden of a driver mutation, but also to isolate subclonal mutations that may correlate with the prognosis. The diagnosis of secondary myelofibrosis is somewhat simpler because, of course, it is necessary to have an established diagnosis of PV and ET. And then there is a high degree of myelofibrosis, grade 2 to 3 on a scale 0 to 3, or grade 3 to 4 on a scale 0 to 4. Again, the diagnosis also requires at least 2 additional criteria, which include, again, anemia, leukoerythroblastosis, increase in the spleen, and the presence of constitutional symptoms. So if you wanted to have a modern diagnosis of myelofibrosis, primary and secondary, it is very important that we integrate not only clinical markers, but also histology and molecular features in order to identify the correct phenotype, distinguishing overt from early PMF and also PMF from secondary MF. Please note that over and over, there is a more prominent role of molecular evaluations, and this is mainly connected to their prognostic impact that we will discuss in a few moments. So I have a question for you all. Which factor would you consider most critical when you integrate clinical and molecular features in the diagnosis of myelofibrosis? You can vote. Of course, bone marrow fibrosis, constitutional symptoms, splenomegaly, anemia. OK? Yes, so I believe that there is no straightforward consensus. Let's see what happens. OK. But of course, the occurrence of anemia, particularly in secondary MF, is extremely important, and also constitutional symptoms. But I appreciate that the sarcoma mutation are gaining some space. Please note that bone marrow fibrosis is essential to diagnosis because histology is the first and major criteria for diagnosis. OK. So let's talk about anemia in myelofibrosis. I was quite surprised and also pleased that there are no many differences between MDS and MF. So we are looking into two diseases that are different but share some quite similarities. We know that unfortunately anemia is very common. We have around 40% of the patients with anemia diagnosis, 1/4 with transfusion requiring anemia, and this percentage is nearly double after 1 year. And this is true for PMF, but it's also true for secondary MF, where 30% of the patient has hemoglobin less than 10 grams per deciliter at diagnosis, mainly post-essential thrombocythemia patients. It was clearly shown that the severity of anemia has a direct correlation with a reduced survival in myelofibrosis, and for a patient with a severe anemia, the probability of death is 4 times higher than for a patient with no anemia at all. So there is a proportionality linking the degree of anemia and the survival expectation of our patient with myelofibrosis. We also know that transfusion dependency is associated with a reduced overall survival at the very diagnosis, but also when transfusion dependency occurs during the follow-up. So also the prevention of transfusion dependency in myelofibrosis should be a key target for our management of the disease. And as expected, anemia and red blood cell transfusions are leading negative prognostic indicators of overall survival in all the prognostic score that we currently use in myelofibrosis. The threshold of 10 grams per deciliter is the most used. However, in the MIP 70, version number 2, there is also a subclassification between severe anemia and moderate anemia, reflecting the proportionality in the correlation with survival, while the MySEC prognostic model, which is specific for secondary myelofibrosis, has a higher threshold reflecting the lower level of anemia that we observed in post-PV patients. We also know, like in MDS, that anemia is associated with an increased risk of leukemic transformation, and this is true if you look at the hemoglobin levels at the very beginning at diagnosis, but also in the patient with splenomegaly and symptoms requiring ruxolitinib. It is not only a matter of prognosis, it is also a matter of how our patients with myelofibrosis live with anemia. So we know that, unfortunately, anemia and red blood cell transfusion have a severe impact on the quality of life of our patients. We know that most of the patient reports that frequent transfusions are extremely bothersome. Hemoglobin levels and transfusion dependency significantly correlate not only with quality of life, but also with fatigue. And when our patient is fatigued, his or her ability to work and productivity is very much reduced. And we also have seen that the patient who requires transfusions spends 6 times more time in the hospital compared to non-anemic patients. And if you look at the cost for the health system, the direct costs are 40 times higher for patients requiring transfusion compared to non-transfusion requiring patients. There is also a cost, an indirect cost, which accounts for loss of productivity of the patients and the caregiver, which is estimated to be 6 times higher for patients who require transfusion compared to non-transfusion dependent patients. And these results were also reported in the United States, who found that transfusion-dependent patients had a higher healthcare resource utilizations, both in terms of higher need of hospitalization, but also outpatients, emergency department visits, and overall total medical and pharmacy costs. So in summary, I think I have explained that anemia is a key characteristic in patients with myelofibrosis. It is a negative prognostic factor for survival. It is associated with a higher burden of symptoms, reduced quality of life, and overall has a tremendous impact on daily life of the patient, their caregivers, and on national healthcare systems, resources, and medical costs. So improving anemia should be really a target for our management of myelofibrosis. So in the next 3 minutes, I will also try to contribute with some genomic impact of our molecular evaluation in myelofibrosis. But first of all, I would like to ask you a question. If you consider a patient with primary MF and a type 1 reticulin mutation, what is the risk for this patient of developing anemia compared to patients with other subtypes of myelofibrosis? You can vote. Oh, wow. So, so this was a good question because, okay, higher, same. It is a type 1 mutation. Good, but not so good. So let's go through the data, and then we can answer again. Let's see if I can move on. Yes. Well, as you may know, 90% of the patients with primary MF may carry a driver mutation, accounting for JAK2 mutation in 60% of the cases, reticulin mutation in 25%, and MPL mutation around 5 to 8% of the patients. So these mutations have prognostical and also phenotypic correlation. For example, a JAK2 mutation is associated with a higher hemoglobin count and also a higher risk of thrombosis, but the outcome is intermediate because reticulin mutations are characterized by higher platelet count, lower leukocyte, higher hemoglobin count, and a superior survival for reticulin type 1 mutation. Because indeed, the type of reticulin mutation matters a lot in myelofibrosis. As you may see, type 1 like reticulin mutated patient has less splenomegaly, higher less leukocytosis, less anemia, less circulating blast, higher platelets, and overall lower DIPSS score, resulting in improved overall survival compared to type 2 reticulin mutation. So to answer the first question, the probability to develop anemia is lower for a patient with a type 1 reticulin mutation. But it is not only a matter of driver mutations in myelofibrosis. Most of the pathogenesis of myelofibrosis is driven by epigenetic dysregulation, which leads to genomic instability, altered gene expression, and finally lead to disease progression. There are many genes that may play a role in this setting and influence DNA methylation, histone modification, or spliceosome function. It was in 2013, so 12 years ago, that a high molecular risk prognostic category was identified by an extraordinary Italian effort led by Alessandro Vannucchi and Paola Guglielmelli, and they showed that harboring at least one mutation in any one of ASXL1, EZH2, IDH102, SLSF2 was associated with shorter survival in PMF. More recently, also the presence of a multi-hit TP53 mutation has been associated with a reduced survival in chronic phase myelofibrosis, also after transplantation. So I would like to ask you my final question. If you consider a patient with a secondary myelofibrosis after polycythemia vera, which risk stratification tool do you think is best for this patient? Okay. Okay, good, but not so good. So I think it's it's important to go again through the data. Let's move on for the sake of time also. Well, for primary myelofibrosis, we have many non-genomic based prognostic scoring systems which are very fine. The first one was the International Prognostic Score System, IPSS, and its dynamic variants, DIPS and DIPS+. They mainly take into account clinical and laboratory features like age, leukocyte count, blast counts, hemoglobin, and constitutional symptoms. However, the DIPS Plus also has the karyotype included, so the first attempt to introduce a genomic variable in our prognostic models. After 2013, the MIP70 mutation-enhanced prognostic score incorporated also the high molecular risk category in our ability to predict the prognosis of patients with PMF. But in the same year, 2018, also the U2AF1Q157 mutation was found to be associated not only with anemia, which is important, but also to inferior survival. And that's why there was a second version of the MIP70+, also including this mutation in U2AF1, and also stratifying the patient according to unfavorable and very high-risk karyotype. And moving along with the desire to have only a genomic-based prognostication for patients with primary myelofibrosis, in 2018, the genetically inspired prognostic scoring system was proposed only looking into driver mutation, type of high molecular risk mutation, and karyotype, so no clinical and laboratory features anymore. This is about primary MF, but we were talking about secondary MF. Well, I think that the most powerful prognostic model for secondary MF is the MySEC prognostic model, which was developed thanks to an international effort led by Francesco Passamonti. The MySEC prognostic model incorporates age as a continuous variable and also some laboratory values like hemoglobin, platelet count, circulating blood cells, the genomic, reticulin unmutated genotype, and the presence of constitutional symptoms. So this is the model to apply for secondary myelofibrosis, but please take into account that there is a new molecularly enhanced MySEC PM, which was proposed at EA 2025 by Barbara Mora. This is going, hopefully, to be published soon, and we integrated the clinical and molecular features of a MySEC PM with a molecular risk stratification, and the most important feature here is that we could isolate a very high-risk category, the UTS, accounting for U2AF1, TP53, and SLSF2 mutations. So again, polling, which genomic findings do you think have the strongest prognostic impact for myelofibrosis patient? Karyotype, driver mutation, ASXL1, high molecular risk mutations. You can vote again. All right. Yes, I think that we can all pretty much agree. Karyotype sometimes is less used because it's more difficult to obtain, because we have many cases of dry top. But I think that high molecular risk mutations can certainly be a guide for our next future in the prognostication. So I think that this was my last slide, and I thank you for your attention.